The International College of Dentists is an honorary organization composed of dentists from throughout the world. The USA section of the college decided to record visually not only the history of the college, but also several leaders in our profession. Dr. H.O. Westerdahl, Secretary General Emeritus of the college, was selected as the outstanding individual to be honored with the first videotape. The purpose of these tapes is to recognize those people who have contributed significantly to the dental profession. How great it would be if we had G.V. Black on an audiovisual tape. Wouldn't it be wonderful to bring back Pierre Fouchard, the father of modern dentistry? Another purpose of this project of the college is to explore the qualities of leadership. What makes good leaders? What qualities lead them to the top? And what can we and future generations learn from them? This program in the series of the Chronicles of Outstanding Leaders in Dentistry highlights the career of Maury Massler. Dr. Massler is interviewed by Dr. William Hopkins.
Where were you 20 years ago?
Right here in Oklahoma City,
Right here in
believe it
Oklahoma
or not. Actually, I came here to speak to potential pedodontists. Dean Robertson was a young man dealing with children, but we had, the academy was newly formed, and they were practicing beautiful dentistry for children without the umbrella of the academy yet. It was very new at that time.
Pedodontics really hadn't been accepted by the public at that time. It was so new.
Not yet. We had pediatric medical care, but dental care specifically for children and for the mothers attached to the children was very new, and very few could do it. You couldn't learn to handle children and mothers in the school, but you sure learned it fast out in practice.
Now, they're a pretty good teacher.
Yes. Yes, especially the mother.
Yeah. I thought that would just be of interest to start at that point before we go back to the early part of your life, because we want to find out about Maury Massler today and his contributions to dentistry, and particularly in the area of pedodontics, because we might call you the modern father of pedodontics, like we call Pierre Fouchard the father of dentistry.
That's right.
Where did you have your beginning? Where were you born?
I was born in New York, in Brooklyn.
In Brooklyn.
I'm one of the rare specimens of a Brooklynite.
An honest-to-goodness Brooklynite.
Yep.
And you came from what kind of a family? What size family?
Just a sister and a father and mother.
Father and mother.
Immigrants, first generation in America. And we, as a matter of fact, I didn't learn to speak English until I was age 5. When I went to school, or my mother sent me to school, and I ran away from the school because the teacher didn't speak Yiddish, which I understood perfectly, but no English.
No English. What, was your father a professional man? Was he?
No, he was in the dress trade.
The dress trade.
He was a very skillful artist in perfecting new dresses.
Did you have any, was there any people in your background that were professionals? Or in other words, what we're leading to is, what drew you into the profession of dentistry?
Yeah. Well, after I finished college, I went into pharmacy. At that time, the NRA allowed you to work and at the same time go to school. So I became a pharmacist. And I worked as a pharmacist for close to 6 years, 6 or 7 years. And then decided that my life was more with medicine, with dentistry, and went to Chicago at that time, 1935, and met Dr. Schauer, Isaac Schauer, who was very good to me and allowed me to continue in dental school and paid me as a research assistant at the same time.
You probably made $15,000 or $20,000 a year at that time in 1935.
Not that much. My first salary was between $9,000, short of $10,000 a year.
Well, that's very good for the 30s.
Yes.
You did very well. And you were in school at this time, studying full-time also?
Yes, full-time dentistry, and the evenings and weekends working in a research laboratory. My first love was research.
Well, there had to be some connection between New York and Chicago. How in the world did you make that connection, being a pharmacist in New York and winding up in Chicago at the University of Illinois?
Got on a train from New York to Chicago and went to the dental school and said, hello, here I am, that's all. No
so
connection.
There was no, it just, you were kind of like a walk-on then.
I'm afraid I had no influence.
No influence. Well, I think you've done well without any influence.
I was lucky.
There.
I was lucky, young man. Just like I feel I'm lucky to be included with your international college.
Well, we feel
amongst the great men that went, whom you have in your archives. I think an opportunity without our control plays a great deal in life's development. And I was lucky. I met Schauer. Later on, 1938, I got to know Orban and Peter Weinman, great men. Sicher. Sicher was my friend until the day he died, which was a long time ago.
Well, when you were a student and started out in research and found that this perhaps was your niche, what was the first type of research work that you did?
I was asked by Schauer to re-examine slides, histologic slides, of ground sections of primary teeth, baby teeth. And I noticed the striations within the teeth, the so-called incremental lines, the growth lines, which I was familiar with in trees. As you know, trees, as they grow, they lay down a line that tells you their age and the environment in which they grew. When I saw these lines, I transferred from the tree to the teeth. And we called it not tree ring analysis, but tooth ring analysis. And in 1936, I was fortunate to identify the birth ring in the primary teeth. And next year, Dr. Schauer went to Vienna and won the scientific award for that year with the birth line.
So that was your very beginning in research, with a long, long history of things that you've contributed to dentistry in the pulpal field and in pedodontics.
Yes.
Very beginning. That as a young man, well, let's see, you'd already been to pharmacy school though, so you weren't quite that young. You were a little bit more mature.
Yes, I was called Papa by my classmates.
Aha, that's right.
They didn't contradict me like they did their own fathers, but we got along really very well because I was older. I had already finished all the courses that they were just beginning, like anatomy and physiology and biochemistry. And it was a nice life. Not very affluent, but a nice one. Good people, good opportunities, and doing the thing which I think I was very lucky to do all my life, and that is to do research.
Did you ever practice in private practice?
Oh, yes.
Massler?
Had about 6 or 7 years right after school. I went into practice just to prove how I couldn't learn from it. I couldn't make any money either, because all the children that came to my practice didn't have money. The parents were poor in that time, the 30s, 38, 39, and 41. And so I got a lot of satisfaction, but I couldn't live on it. Besides which, research was the important thing. For that, that was a life, an academic life, which was very fulfilling. It was worth more than all the money in the world. And I still think so.
Good. But was there something in your life as you grew up that drew you to the children and brought your attention to the children, or was this, you felt that they were being neglected because you have been so vitally interested in them?
In retrospect, if you want me to be honest,
yeah.
I think I went into the field of pediatric dentistry and periodontics because there was very little competition. Remember, at that time, the average dental practitioner was afraid of kids. He wouldn't take care of them. He would pull the rotten teeth without practicing preventive dentistry as we understand it today. It simply was unheard. Now, pediatric medicine was just beginning, 1922, 28. A pediatrician was just beginning to be known as a physician who knew how to take care of the needs of children and their parents. Dentistry was a late bloomer, and it was not until about 1941 that pediatric dentistry became known to the public, that there were dentists who were specially educated to take care, to practice preventive dentistry, to take care of the fears and the anxieties of the mother watching the child scream in the chair. We had to learn a great deal which were not in books. And that was a challenge. That was wonderful. I still remember one incident. I had done a piece of work on thumb sucking, which you remember everybody deplored, that it was bad for the teeth. It pulled the front teeth, it made them look like a rabbit bunny with the front teeth. And our research showed that it was a substitute for a mother, the mother's nipple actually, and they needed this thumb in order to be quiet. These were contented children, not bad ones. I was then an intern in pediatrics where a baby who was crying and wanted to suck his thumb, they used to put a nightgown on with the hands tied down. Yeah. Well, that was horrible to me. This was inhumane, shall we say. It was a lack of understanding that there was a very important, complex, but important living being attached to these teeth. And that the person was much more important than a few teeth which we can correct anyway.
Right. So this led you eventually to form the Academy of Pediatrics.
That's right.
Pedodontics then at that time.
American Academy of Pedodontics was a new concept. I was, again, very lucky that I worked with outstanding people like George Teuscher. Beautiful people who were dedicated to this. And they formed a group, and we persuaded the government to give us a license to exist. No money, but we became an academy, and from that year on, from the year 1946, certainly, the attraction, the education of the public and the attraction of bright, young, skillful dentists who could get all the patients they wanted as long as it was a child patient. You know, the older generation didn't want children. They were not as profitable, and also they were more difficult to handle. You can take a dentist who's been in practice, he's about the age 45, 50, a little child, even his own children were teaching him to treat them differently, but it was a new era. So the Academy flourished beyond our wildest dreams.
Well, that's wonderful.
And now I'm in geriatrics. Do you remember
yes,
that?
We're going to get to that a little later on.
Good.
If you don't mind, I'll interrupt you on the geriatrics. I want to continue a little bit along the line of the children, because I know after World War II that you were sent to Italy to study some of the post-war effects on the children that have been ravaged without any food. I mean, almost starvation. And to tell us a little what you found over there.
Well, UNRAD, the United Nations Relief and Rehabilitation Administration, felt that it was important to pick up the orphans which had been abandoned, who had been abandoned in the streets. And Italy was a sort of a concentration area. We pulled them out from Yugoslavia, from Czechoslovakia. I still remember the beautiful little girls, age 4 or 5, who were filled with tuberculosis, no parents, nowhere to go, and we could pull them down through Switzerland, who let us stay for about 10 days. And then in Naples, we could put them into a hospital, which was a transformation of an old villa up in the Vomero, up in the hills. And it was an exciting area because I learned so much from this group of young people, their fears, their anxieties, and how to handle it. To distinguish between fear of a real object and anxiety. Anxiety is defined as a fear, but it's a subconscious one. Fear of dying is an anxiety. It's not a real fear. We can manage real fears, like thumb sucking.
Yes.
There's no problem there. But the deep-seated anxieties which make the difference between a very effective periodontist and one who just drills and fills teeth, we're past that era. Today, the modern young mother knows that this child is a delicate, complex organism. Teeth is part of the problem, but it's not the whole problem. So our modern periodontist is as much a psychologist as he is a skillful technician.
Very true.
He's above the technique. And people are beginning to recognize that. The profession, that is the medical profession, is beginning to understand. And very happy to have lived through this era.
Now I'm going to take you back to Italy again because
Yes.
I want you to tell us, or tell me or us, what you found with these near-starved children as far as their oral health compared to their rest of their health symptoms.
That's a good question, and we've written extensively on that. The question was, is nutrition a fundamental basis for defects in the teeth, in the growing teeth? Because we had just finished almost 100 publications where this was examined in animals. And we found, no, in the growing tooth, in the rat incisor, which grows all throughout the life of the animal, you could imprint in these structures deficiencies in calcium, deficiencies in magnesium, zinc, vitamins. And that was an era when we began to learn about these things. In Italy, Dr. Shah and I were given the responsibility for investigating the caries attack rate in nutritionally deprived. There were hundreds of them, thousands of youngsters, also adults. The adults had beautiful teeth, strong teeth, even with fluoride in the water supply, which was a natural. You find that in Italy, they have natural fluoride. You don't have to add any, as we must do in this country. But what about the children with the growing teeth? It showed that dental caries did not depend upon nutrition. It depended more about the lack of sucrose type of sugar, and they didn't have sugar. You know, the average American consumes about 140 pounds of sugar per person per year in the form of candies. In England, they were reduced during the war to 10 pounds of sugar per year, and the teeth were wonderful. In Italy, they had less than 1 pound per person per year, and the teeth were beautiful. But they lived on raw vegetables. In Naples, I was stationed in Naples, they lived on garbage, the remnants that our American soldiers just threw out. It sustained the entire city for almost to 4 years. The teeth were marvelous. And I must tell you, we did one study in Torre del Greco, that's up in the mountains, and they have a lot of apple orchards. If you want to sell apples, that's a good place to start, because they lived on apples and apples, no beef, no poultry, no milk, but the teeth were beautiful.
What happened when the GI came in with his chewing gum?
When the GI, who was a wonderfully humane type of person compared to other types of soldiers, they were very kind to the children, and they gave them lots of chewing gum, not so much chocolates, but chewing gum, and these kids would go around all day long chewing and chewing and trying to speak American English. The teeth soon deteriorated pretty badly.
Which substantiated your sucrose theory again.
Oh, yes. It was the start of, I think, a long history of evaluation of which of the nutrient elements are responsible for more specific diseases like dental caries. It was more specific than recognized before that.
You've mentioned Dr. Schauer and Dr. Orban and Dr. Weinman. Would you perhaps consider these some of your role models in dentistry that were very, very important in...
By the time I got to know them directly and work with them, they were already worldwide famous people who had done fundamental work in basic stomatology, they called it. Didn't call it dentistry then. It was more than teeth, it was a whole mouth, a whole organ. As a matter of fact, it's not recognized that Orban, for example, brought to this country the first consciousness in periodontia. Periodontology, of course, is very well advanced in this country. But in 1938, when I picked him up at the airport, it was he was known as a periodontist, a unique individual. And Peter Weinman was a scholar. The great pathologists that are with us today were trained by Dr. Weinman. And Schauer was probably the most effective scientist scholar. He was the one that initiated the thought that when we're talking to students, you're talking to people who are learners. They're not students whom you persecute. That if you are a good educator, you brought out from the students their potential, their wanting to learn. And he was master. He was the best of the whole lot. One of the early educators in this country.
And then Dr. Sicker.
Sicker was the grand old man. He was so bright, incidentally, he was not a dentist. He was a MD, and his forte was surgery. His belly surgery and all sorts of surgery was just exquisite. He was marvelous, he was ambidextrous, and he could operate from either side beautifully. He loved to demonstrate that. Oh. But intellectually, he was a gifted mind who, in this country, he already had written the outstanding textbook in oral anatomy, translated from German into English. But he became an expert in cementum. That's the covering of the tooth. And I think of all the people I've ever known, he was by far the most intelligent and understanding about tooth structure.
Well, since you spent so many years of your life in research, and you have followed this and done the research yourself, what's your feeling about research today as far as dental research is concerned?
Dental research?
In the United States, let's put it there first.
Yeah. Well, we're still ahead of the rest of the world by far. In dental research, we receive grants which are very, very helpful. But I think the shift, as I see it, has been from working with humans as wonderful objects, guinea pigs if you want, who suffer from a variety of ailments, and we can learn a great deal about and from the sick people, especially the older ones, if I can interject. There is a greater emphasis on more fundamental science. The biochemical changes, the immunological aspects. For example, in periodontology today, Orban never imagined it, and he was well ahead of his time. the immunology of the disease, which affects the soft tissues, the structure of the bone, and the fact that the bone depends upon the calcium input, that there has to be a balance. And as the bone that supports the teeth, the bone is related to the bone that supports the spine. So that when you see an elderly person on negative calcium balance, who's hunchbacked, who is shriveled quite a bit, lost 3 to 4 inches in height, you begin to take a look at the bone that surrounds the teeth with a little more intelligence and understanding, and not blame the patient for not taking care of themselves. Mm-hmm. It's more fundamental than that.
So the role of the dentist is becoming more encompassing in general health than it used to be. We're just not the drill and fill people that we were for so many years.
I like the term that you find in Europe. They call us stomatologists rather than dentists. The translation of dentist is a toothist. Well, we're far above that. We're stomatologists, and eventually there'll be another word, that we're taking care of people attached to the mouth as well as to the teeth. For example, in a recent publication, I pointed out that denture failures in the elderly is due to the tissues which cannot withstand the trauma of a prosthesis. It's not that the skill is less. He's more skillful, the materials, far superior to anything that I learned when I was a student in 1939. But the tissues, the living tissues that we ask to take care of the prosthesis, the difference in the bone structure, the epithelium particularly, which becomes thin and fragile, the dryness of the mouth. Mm-hmm. Xerostomia is a real problem. No matter how well you make a denture, if you put it in a dry mouth where the epithelium is very thin and easily bruised, there's not going to be success. And it's not his fault, it's not the patient's fault. Someday we'll learn how to overcome when we recognize these deficiencies. It's coming quick. You asked about research. That's where research is going on.
It's needed.
Yeah.
In talking with you, I forgot, I guess probably last night, came up that the rat was your favorite research animal.
Oh, yeah.
Why was the rat your favorite research animal?
The rat is a favorite dental research because it has 2 types of teeth. It has incisor teeth, which grow continuously throughout the life of the animal. And as it is growing, the changes in the metabolism of the individual is recorded like on a chymograph. It's recorded within the structure of the teeth so that later on we can take these teeth, section it, and study it microscopically to find out what was the systemic condition at that point. The rat also has molars, small molars. You know, I learned to make cavities in tiny little rat molars under a microscope before I went into the human clinic when I was a junior, I think, the second half of my junior, and to drill and fill teeth in humans was a joke. It was so easy.
So you started microdentistry long before?
Oh, yes. I served an internship, I'd call it, with the animals. The animals were very important. Remember also that in the 30s and in the early 40s, the rat had also been known to be a perfect test object. Before we used humans by giving them new drugs, new antibiotics included, tranquilizers. You used it in animals, and they were much better than dogs or monkeys. We also did a lot of work on monkeys.
You've done a lot of work with the pulp and inflammation, irritation, and the reaction of different restorative materials on the pulp. And I have a little booklet here that was written in January 1958, Practical Dental Monographs, Pulp Protection and Preservation by Maury Massler.
Yep.
Now that is 30 years ago almost. Do you see any basic difference in pulpal protection today as when you wrote this book?
Oh yes, it's changed quite a bit. In those days, restorative dentistry, operative dentistry, we used slow speed hot burrs, we call them. And when you use that to drill into a tooth, the heat given off and the dryness that occurred injured the pulp, which was a living tissue. As a joke, I say that we had to invent the endodontists in the dental profession to bail us out of trouble.
We may be in trouble.
It's not exactly correct because endodontia today is much more scientific.
Oh, yes.
How have we changed? High speed, cutting with coolants, using protective bases over the injured pulp so that it can recover. In 60 days, even a badly injured pulp may recover underneath a temporary or semi-permanent filling. This was unheard of at those times. When the patient showed up after having the tooth drilled and it was aching, you pulled the tooth. We don't do that anymore. If it is aching, we treat the pulp as a living tissue and take care of it. Has there been advances? Oh, tremendous amount of advances. Every one of the filling materials that we used to use that might injure the pulp are no longer used, like silicates. We still use the amalgam, but that's being displaced a good deal about the modern composites. The modern composites are marvelous new materials.
But we're still using base materials, calcium hydroxide materials,
Yes.
zinc oxide materials.
Right.
So these basically haven't changed in the last 30 years.
I think there's a better understanding of the mode of their action. Zinc oxide and eugenol, which incidentally I first introduced here in 1966.
Right.
I think some of your colleagues here still remember that. It came as a revelation that this old material that goes back many, many hundreds of years in use empirically, now we could explain that it had an anodyne action, it relieved the toothache, it promoted healing. The calcium compounds have come. We used to use calcium-based bases, which were really merely protective bases. Now we can use substances where you release calcium so that they can remineralize part of the dentine, which we leave behind. And that has changed. We used to dig down into a tooth. The infected material, we didn't know that there was a difference in infected area, affected but not infected, soft dentine. We learned to respect the fact that you're dealing with living tissues, and you had to be much more careful as a dentist in respect to living tissue to promote its healing than in medicine. In medicine, no matter what you do to some patients, they'll recover.
In spite of the
And no matter how much you try, some patients don't recover.
That's true.
It's not the magic drugs that we have. It is the ability to handle the human being so that you promote healing, you don't depress them into a stage where they die on you. Same thing with the tooth, same thing with the pulp.
I can remember after attending your presentation on zinc oxide and eugenol, somewhere down the line came the idea of incorporating silver filings in the zinc oxide and eugenol, and that was probably the beginning of the first miracle mix that they're using today with the glass ionomers and the silver. That made a tremendous restorative material.
Well, actually the experiments were done in the Navy on young people who were scared to death of the dentist, so we took away the infected material and then put in a temporary filling, but it had to be reinforced with amalgam filings. And it saved an awful lot of teeth. And it made the youngster who was afraid of the dentist a little less afraid. That was important.
Let's get back to your educational experiences when you were at the University of Illinois, after you became a graduate and started the pediatric department. Would you tell us a little bit about that experience in the beginning at the university?
Yeah, well, up to 1941, care of children was in a small chair in a corner of the big clinic. It was, shall we say, an unwanted child. And the treatment of the child and circumstances like that did not impress the students, so that when they graduated, they didn't recognize that there was a difference in the handling of the child. About 1941, and certainly by 1946, then it had grown in stature. I'll never forget that while we were forming the academy, that suddenly it occurred to us to also promote not only education of the public, but education of the organization, the American Dental Association, when we said children's dentistry should have the same status as other specialties in dentistry, like restorative dentistry, like prosthetic dentistry, like periodontics. And by 1946, this was pretty well established. The average young mother knew that she had to find a periodontist, because otherwise that child might not be accepted by an older dentist. That's nothing to say about the older dentist. In school, nobody told them that a child was different.
Did you head up the first department of pediatrics at the university?
We were the second. George Teuscher at Northwestern. Me? Yes.
At the University of Illinois?
Yes, I was the first.
You were the first one.
I had finished a lot of work in pediatric medicine. I was in charge of the hospital dentistry then, and served an internship with some wonderful people. Dr. Richmond was one of my classmates, and he was very good. There I learned that the feelings of the child, the feelings of the mother, were terribly important. If the mother was outside of the operatory and the child was sitting in the chair and crying and yelling and sometimes violently upset, then we had to recognize that there were ways of handling the situation. For example, I taught some students to allow the mother to sit in the chair, and then her child was held in her lap. The child was secure. They would open their mouth, which they wouldn't do before. They would allow me to take a peek, and I would introduce gently a mouth mirror, not a sharp burr that scares the hell out of them. And it was a period of learning. I hope I'm still learning.
You are. Not
only with children, but with and my grandchildren.
How long did you stay at the University of Illinois?
Until 1973. From 1935 to 1973. It was a long time. And I'll be honest with you when I say that the only reason I left was that my pals were all dead. There was nobody left.
You were left alone.
And I was alone. I felt alone. And when Bob Shira became the new dean of Tufts, I had worked with him in the Army for about 12 years on and off, and he asked me to come to Tufts. I was tickled to death. Besides which, Boston is such a beautiful city, such a cultured city, and my wife is a pianist, and she just finds the atmosphere there so culturally conducive to her best aspirations. So it was a good transition. I was lucky again.
You were at the right place at the right time.
Right.
Wasn't most of your work at the University of Illinois with graduate students?
Yes. For the last, I would say, 18 years at Illinois, I dealt with graduate students. I had, if I may brag a little.
You may brag.
I had more than 80 graduate students over that period of my life. About 80% of them became full-time academics, deans of schools, heads of departments. It was a wonderful, wonderful thing.
That's something you can be very proud of.
Yes.
Those that follow, that you have led, and they follow, and you can see their successes.
Well, as my wife Hildy says, I'm very honest, students love me, poor as a church mouse.
Well, maybe monetarily, but maybe not.
Oh, in lifestyle and people, very rich. Aren't you going to ask me a question about the older generation?
Oh, we're going to get to that, because you're still a young man.
Well, hurry up. The time is getting
Oh, we
close.
have lots of time now. Let's
Good.
don't rush things here. I want to talk a little bit when you went to Tufts.
Yes.
I think there was a program that Shire wanted you to investigate about a 3-year curriculum.
Mm-hmm.
And I'd like your views on that, what you thought about the, what you found out, and your thinking and final thoughts were on 3 years.
Thank you for asking the question, because it's an important one.
Yes.
You see, about that time, that's 1973, the United States Congress felt that we were spending too much time educating physicians and dentists, that it should be done in a much shorter period of time, compressing the knowledge. After all, we had wonderful books they could study. You didn't have to lecture at all of them. That memorization of facts was not enough. It was understanding of these facts which was important. And in dentistry, they thought that this could be done in 3 years instead of 4 years, which was the amount of time needed. Incidentally, in Europe by that time, they recognized that it needs more time to learn, to understand, because technical excellence isn't enough, whether you're a physician or a dentist. It's not enough in medicine, for example, to know that we have laboratories which are very sophisticated. They spew back data, which is very important. But does he understand how to utilize these data? That's the point. I would say by the time I reached in Tufts, they were on an experimental program, on a 3-year program. When Bob Shire asked me to take over the clinical teaching, I found very quickly that it was very stressful on the students. The students simply did not have time to breathe, to go to the movies, to say hello to friends, that they were always on a treadmill which was going much faster than they could keep up with it. They were imbued with taking so many examinations in order to pass, to survive, that they didn't learn to understand the important things about people. But people orientation was no longer present. You passed exams. Also the staff, and I had a wonderful staff. I had inherited outstanding practitioners in the areas who gave us 1 to 2 days a week in education at virtually no pay, and they were very frustrated. They almost cried with the stress that was placed upon the teacher as well as the student. And therefore, I recommended, and Dr. Shire was intelligent enough to accept that 3-year was not good. As a matter of fact, if I want to be honest with you, and maybe somebody who will listen to us, 4 years is not enough. That we should have at least a year of internship, like the physicians have, where the contact is with people and learning from people, learning from clinical experiences. I'm not sure that 5 years is enough.
Well, I know I read here that you felt that at least a minimum of 2 years for the specialty and the specialty of general dentistry.
That's why we have specialties.
Right.
Each one of them requires at least 2 years after you graduate as a dentist or as a physician. You need 2 postgraduate years in which to really begin to put together this enormous amount of knowledge. And you learn understanding, you learn to utilize what we have learned. Is 2 years enough? For specialties, fortunately, we made it mandatory. You have to spend 2 years to learn more than you possibly read from books. It's not enough.
Do you think that'll ever come about with the practice of general dentistry?
Yes. I think that a general dentist needs to know a lot more than a specialist. A good general dentist, like your international group, are excellent clinicians. And can they learn? It takes them about 20 years in practice to learn it. Mm-hmm. I think they should have 2 years in general dentistry to learn how to take care of the multiplicity of problems that living people present to us. To give you an example, in elderly patients, there are some patients who don't want a new denture. They want to talk to me. They want the 20 or 30 minutes in which to tell me about their grandson, right, about the fact that their son doesn't have time to come and have a Sunday dinner anymore, and they feel it. Now, is this the area where a good clinical dentist should be more sophisticated? Yes, of course he should. He's dealing with human beings. That we don't, I'll tell you the honest truth, we don't know enough about human problems, about depression, for example. We can recognize it when it's too late, but we don't know enough how to prevent it.
Well, I think the general dentist gets caught up in a busy practice, and he doesn't take that time to sit and talk with his patient and learn the patient as an individual.
It's not new. You take Menard Hine, who was here.
Yes, Menard was here.
He understood the humanism of dentistry when I was a student. He was one of my teachers. Harold Hillenbrand is thought of as being a financial genius. He was more than that. He understood that to be a profession, it had to have stature and respect as a profession. And one of my problems in education is to interview students who want to become dentists. Are they interested in a practice based upon a good income, which is almost assured these days, or do they want to be called doctor so that they can take care of people? And about 11–12% of the young people want to practice dentistry as a profession, not as a trade. That, I think, is true.
That's good. Should be more.
Yes, it should be more, but once you get more than 10–20% of the population, these are the cream of humanity. You can't ask for more than that. Too many are mediocrities, and some of them are not quite adequate. It's a pity.
You're on the admission, you were or still are on the admissions committee at Tufts.
Oh, yes.
So this gives you an opportunity to see these young folks before they begin on their career.
I am surprised, and I must tell you quite honestly, more and more each year want to become a professional person. They want to study dentistry in order to be of service to humanity. The Hippocratic Oath is not an abstract thing to them. It's really true. And if you talk to some of our young people here behind the camera here, he understands and she understands that a dentist has to be selected on the basis of his dedication to treatment of people rather than how many Cadillacs he can afford. Or his wife wants too many fur coats. You can live without a fur coat, and my little car can get me just as well as the next Cadillac.
Do you notice on your position on the admissions committee, do you notice any difference in response of the female applicant to the male as far as their thinking and concern with the future of their profession?
I think the women who apply for dentistry in general are more aware of dentistry as a profession in which they can enter. They can work even part-time if they want to grow a family. That it is a way of life that's very rewarding. And there are plenty of male students also that way. But there are a large proportion who are Americans, who are they want to be doctors in order to make it good in the American hierarchy, in the American scene. As a patient, you better choose your doctor carefully for how much he loves you, respects you, and wants to take care of you rather than your pocketbook. It's not easy, but there are many of us who are interested in you as people.
In your graduate program, did you have, or have you had very many females in the graduate program?
More and more each year. I would say that it's, in the graduate program, about 35–40% are females now.
Oh, wonderful. That's...
Yeah, many more than, let's say, 20 years ago. When I came here 20 years ago, I think in the academy we had, well, there were 3 outstanding ladies who were superb clinicians.
Yes, I think I heard a figure of there's about 25% of the incoming classes now are female.
Yes.
And this is continuing to grow, that they find that they make a very, very fine professional.
Oh, yes. Much more dedicated to the patient, willing to take time to listen to them. As a matter of fact, at Illinois, we had a simple approach in pediatric dentistry where the graduate student went to the home of the patients to have lunch with the parents, because then his understanding and their understanding was greatly enhanced. Of course, today that's a hard thing to require. The average student thinks this is kind of funny. To learn to live with your patients, to break bread with them, it's very important. Yeah.
What do you see as some of the major changes in education as far as the teaching, from the teaching standpoint, from the last 20 years?
Within the last 15 years, I would say, there is a change in the attitude of the teacher. The teacher used to be a purveyor of facts, knowledge, and he got very annoyed with you if you didn't listen carefully. And we called him a teacher because the inference was that the teacher was so important. If he was intelligent, had a good record in research, that automatically became a good teacher. Not true. We now speak of the learner. The student is more important than the teacher. A bright, gifted student will learn more dentistry in spite of bad teaching. Now, if you have a bright student and a good educator, you have the combination. It's the difference between, well, in music we knew this a long time ago. You give a youngster who means well a Stradivarius violin, and if there's no talent, it doesn't sound very good.
That's good.
If you have a punitive teacher of a person who wants to learn the violin, he won't learn it too well either, even if he's a genius. But if you have a Piatigorsky as a teacher, the cellist, he was a marvelous teacher. Now you give him a beautiful cello, and you put it into the hands of a talented student. Now you have music, which you can hear and enjoy every time. It's not just the notes on the paper. That's music. And let me tell you, that's the profession of dentistry. And it's the profession of medicine. And it extends even to the profession of law. A lawyer who loves law and the people who are exposed to it is a lot different than the lawyer who chases ambulances.
Right. Of course, today the composite restorative material is probably one of the biggest boons that's hit dentistry since the advent of the high-speed turbine handpiece. But going through some of your CV and biographical sketch, I noticed that you participated in the first workshop on adhesives in Indianapolis with Ralph Phillips. Now that was in 1961. Tell us a little about that workshop and what you remember went on there.
Yeah. Well, Ralph Phillips is a wonderful example of a scientist who knows how to educate other people, particularly other dentists. He himself is not a dentist.
That's right.
But he knows more about dentistry than the average dentist. Ralph felt strongly that he needed to bring together scientists in the basic sciences of adhesion, cohesion, adhesion, and that we needed to learn a great deal more about the filling materials that we were using. Because by that time it was recognized that if we could ever invent a filling material that was adhesive, that is, it stuck to the cavity, you wouldn't have leakage. You might remember that about 61, and certainly by 1958, we were very conscious that filling materials leaked. They leaked badly. So that if you did a beautiful filling, but you put it into a saliva, which was infected with the strep mutans, for example, that you'd have secondary decay. That meant that the margins needed to be closed up. And we tried all sorts of things. And one of the things that was in the minds of the clinical researchers, like Ralph Phillips and his colleagues, there were many others.
Oh, yes.
Don't remember all their names, but they were awfully bright in that they were thinking in the future. That if we could only have something that stuck to the walls and didn't leak, that it would make a beautiful filling material. And we're getting close to that. The modern composites, which is a filled material of a number of different long chain materials, that offered some hope. So he called a workshop in 1961, there have been many since that time, which showed that the basic science had to be understood a lot better. And from that, there soon came many of the modern filling materials, which are wonderful. Just make them a little harder, which sounds as if they're coming to it very closely, so that we can gradually push out the amalgams. You can't use amalgams in the front of the mouth, but you sure can use beautifully the modern composites, beautifully. All we need is a few more dollars, a few more dedicated scientists, and we'll now be able to fill the back teeth as well as we do with the front teeth.
Did you do much research in materials, or most of yours with pathology and histology?
Most of mine had to deal, let's say, with marginal leakage, for example. The reaction of the pulp. The reaction of the pulp to based and unbased amalgams, for example. You may remember that was the time when we recognized that if you used an insulating base under a metallic filling, that the pulp was wonderful. There was no toothache. It would recover. It would build what is called secondary dentine or reparative dentine, more accurate term. And if you put the amalgam directly without a base into the cavity, that it would stain the dentine. Some of the mercury in the tin would percolate into the depth so that you couldn't use it in the front of the mouth. It would discolor the tooth. Whereas in the back of the tooth, which is in a shadow really, it didn't matter so much. But we're getting smarter and wiser. I would say wisdom is beginning to percolate into the brain of the dentist.
And we're becoming a little more cosmetically conscious also.
Oh, yes. Aesthetics in dentistry is now a subject unto itself.
Oh, yes.
There's an excellent text on it.
And a lot of new terms that are coming into dentistry.
Yes, inevitably we invent new terms.
Invent them. I know part of your job on the faculty at Tufts, I think, was to not only educate, but to educate educators to teach. Yeah. And I know that you've been worldwide with this. You've been in Israel, you've been in Europe, you've been in South Africa, and I'd like to just kind of sit back and listen to you, some of the things that you've done as far as creating new schools and new faculties and teaching, and some of your experiences outside of the United States.
Mm-hmm. Well, that was one of the main objectives intended by the Fulbright Awards. You know, Senator Fulbright, he's still active, he's still going around. As a matter of fact, I will be seeing him next month.
Oh, good.
The object there was to recognize that a building, expensive these days, and then maintenance people who are even more expensive, and then teachers who are not expensive, but we don't have enough educated teachers, that one of the functions was to go to different places and in the new schools with new faculties have a double job. Not only to educate the future teachers in the technology, the new technology, but also to educate the teachers to become educators. Now, the difference between a teacher and an educator is a broad one. A teacher is a person who is loaded with facts, a lot of knowledge, and he's very anxious. If he's a dedicated teacher, he's very anxious that the audience appreciate and listens carefully. An educator is a little different in that he is more concerned with the student, his growth and development, recognizing that we have some students who are very talented, and we mustn't squash that talent. We mustn't impose upon them to make them average. There is no such thing as average anyway. Mm-hmm. And that some students need a lot more time. They need a lot more direction. And to become an educator means that the modern faculty of medicine and dentistry both is very much aware that he is an educator beyond the limits of just being a forceful teacher. So that some of the new schools, for example, in Israel, there was first the Hebrew University, and in 1960 they had a new faculty, and my job was to educate the faculty. They were all very intelligent. Their background, almost all of them had come out of Germany, been forced to flee. They were already a highly educated group, but they didn't know how to teach. Mm-hmm. So we had to educate them in the learning process. Magnificent. 10 years later, we opened a school in Tel Aviv. And 10 years later, a medical school in Haifa, at the Technion, part of the Technion, where the emphasis was in promoting learning in students. And in South Africa, did that in 3 of the places. In South America, a lot of the schools, of course, there are only new schools. Old schools don't exist there because it has to be built up by dedicated local people. Whether you're talking about Chile or Venezuela, it's a matter of dedicated professional dentists who like to teach. They are anxious to learn how to promote learning in students. And I must be honest to say that the students, especially even today the modern students from Taiwan, for example, or Thailand, these graduate students are anxious to learn. You don't have to teach to be a good teacher. You just need the textbook, the information, and they're very grateful because when they go back to their own country, they do an enormous amount of good. In the early years, we had a lot of people from India, and they would go back then to their old schools and bring forth a generation of dedicated, excited students who became professional people. Yeah.
So that has been a very rewarding experiences, I'm sure, in all these, I would almost say, underdeveloped areas at the time.
Yes.
And you've seen what has happened over the years.
I think my wife, Hildy, puts it best. She says, there is not a single country in the world that we have stepped off an airplane without a former student there to greet us, to take us into their home. I rarely stay in a hotel in Europe, for example, or in South America, or in South Africa. We stay with a former student who still introduces me as his teacher.
So you're really the guest in the country rather than a tourist.
Oh, of course.
That gives
Wouldn't
you,
go as a tourist.
Gives you a great advantage.
Yes.
Great advantage. I know earlier on in our conversation you were quite anxious for me to talk to you a little bit about the older aspects of dentistry. Yes. And geriatric dentistry. And in reading some of the things that I received from you, that you felt that you were well qualified to speak of geriatrics for two reasons. One was because of your experience, and two was because of your age.
Yes.
Now here you've gone from one end of the spectrum, the child, and made a tremendous contribution to dentistry with pediatric dentistry. What are you doing with geriatrics now?
Geriatric dentistry was attractive to me, not only because I'm past 70, but because the population now, if you read the statistical numbers, we're getting to be an older civilization, an older country. We have more elderly people past 65 years of age than we have children entering the schools.
Mm-hmm.
About 21% versus 14%. And I think the children are in good hands. They'll only improve with time. But the neglect of the elderly has been a bad aspect of our own development. The average practitioner is not equipped to deal with the problems of the elderly. And these problems are as different as problems in children versus adolescents during adults. Adults are different from adolescents, and adolescent care requires an extraordinary amount of skill and understanding, mostly understanding. But the psychobiological changes that distinguish a young lady from a child, a female child, are tremendous. Mm-hmm. Well, we have change of life like this. We have 4 times in our lifespan. Birth means that you change from one environment to another one. The whole body is different, and it's important. The change from a pre-adolescent to an adolescent with the endocrines and the psychic changes, that the physical changes are enormous. And then during adulthood, the menopause. Women, you can tell that there's a difference between premenopause and postmenopause. There's a lot of problems, psychobiological. And then we have the 4th change in life, when we get to be less vigorous. The memory sometimes is not as sharp as it was before. The aches and pains. Getting up in the morning is a little bit difficult for me. The joints aren't oiled up the way they should be. And so we've done a lot of investigation in terms of, in the human, what is the most important nutrient for the elderly? Is it vitamins? Is it carbohydrates? Is it so simple that you reduce the carbohydrate and increase the protein intake? Is that enough? For the bedridden patient, calorie protein deficiencies are very common and very important. But you deal with the average factor of aging. For example, my work is with water needs. Mm-hmm. It turns out that water is more important as a nutrient in the elderly than all the vitamins, all the proteins, all the carbohydrates. Man can live only for about 10, 11 days without water. Even those that go on a fast, Gandhi, for example, always had water, water, even though no carbohydrates, no fruits, no nothing. We had to learn that the water that is bound with the protein, like in fruits, is more important than free water. My last paper, I pointed out the difference between taking water from the tap and drinking it. It'll appear in the urine within 1 to 2 hours. It's not absorbed, but you take the same amount of water and you put it in with proteins, meats, fruits, and it goes down slowly, and when it reaches the colon, it's reabsorbed. Just like the saliva, you swallow it. You don't spit it out, otherwise you'd become water deficient. Pointed out that drying up of the skeleton, of the skin, the wrinkling, these are all very important. And from a dental point of view, that the drying of the mouth is most important, because then the denture won't fit. That, sure, you need more calcium. Otherwise, the bony ridge resorbs very quickly. It'll resorb anyway, because an older person is in negative calcium balance. But eating a lot of Tums is not the answer. My question to one of my colleagues who had the new discovery that Tums is calcium, wonderful. I said, is it absorbed once it gets to the stomach? He says, why not? I said, because the stomach doesn't have much acid. When you're 75 years of age, you don't have a stomach that's acidified. You have to feed him foods which are acidulated. Cottage cheese, for example, yogurt. That calcium is useful. It's part of the body. It replaces the calcium that's coming out of the bones every day. That activity is important because the circulation of blood around the organs is terribly important. That if he's so old and living alone, eating practically nothing, depressed, he is going to die nutritionally. Just giving him Tums is not the answer. So there's a lot we have learned. And if you're interested, I'll send you a reprint on water needs in the elderly. For example, I am now investigating the water. 5% of the water of the human body is in the form of gel around the joints and the cerebral spinal fluid. Now that water, although it's only 5%, is terribly important, because if in lack of water the joints get stiff, it's like the oil in your car when you lose too much of it. Then they get up in the morning, or we get up in the morning, and it takes a little while to walk straight standing up. Otherwise, it's difficult.
Take it in stages.
But what bothers me a little is the tendency of the advertisers to stress the simplistic aspect. They should have calcium. Well, that's not the way to use it. The way is in the food supply, combined with other nutrients. Otherwise, it has no value. Well, I wouldn't say it has no value. It has minimal value.
Well, I don't know of anything that's simple that has to do with the human body, that you can just take a magic pill and it corrects everything. Along that line, I know we were talking at lunch about one of your research projects that you had started but you didn't get to complete, about moving the elderly in with a family.
Yes.
And I'd like to have you discuss that a little bit, because that was very interesting, not only from a nutritional standpoint, but psychological.
Not new. It's just that I was made aware of it more emphatically. We dealt with widows living alone, without a family, and we were interested in their nutrition. What do they eat? Well, if you're a widow living alone, you don't prepare meals like for a hungry husband who comes home. And you live on dry toast, warmed over tea. That at the end of the day, the amount of nutrient, actually they starved themselves to death. About the same way as I saw in Italy during the war. They were really starving elderly people. Also, they became very depressed. The outside world ceased to have challenge, interest. They didn't read the newspaper from the front page to the last. They started with the deaths to see if they could recognize some of their friends. It's an entirely different human beings. Now, our project was to take some of these and put them in with the family where the wife was working, but they had 2 little kids. One was enough, but 2 was better. 1 little baby that needed care, and grandma was induced to live with this family. 1 grandpa and 16 grandmas. They went to live with the family, and the difference, they became alert. They were anxious to wheel the baby for a stroll through the park instead of staying at home doing nothing. And their aches and pains disappeared. It was surprising. Even though she had arthritis, if she was a family, she could manage it. Living alone, it was a disaster. So it's more than water, it's more than calcium, more than proteins. It was living in an environment. The amazing thing that in this still incompleted work was the change in these people. It was a longitudinal study. It needed to be carried out over a minimum of 5 years, by which time I had changed. But it's quite evident that if you want a healthy grandmother, if your mother is living alone and you don't talk to her and she is depressed, she will die soon. But if she lives with your family and takes care of her grandchildren, she won't die. She hasn't got time to die. She'll do much better. Of course, being a scientist, we weighed each part of the food and how much and what type. It was fantastic.
Well, they feel they're needed. There's a need and there's a purpose for them to be on Earth in that situation.
Of course. Oh, yeah.
And if you feel better and you're needed, you're going to eat better.
Well, sure. You take some of these octogenarians, 100 years of age, still vigorous, still working out into the field. It's because they're doing that to help the family. Alone, they shrivel and die very quickly. Now, I'm not sure that the world is ready for that type of thinking. See, in America, in our affluent society, we take these bothersome little old ladies and we stick them into rest homes, they call them?
Nursing homes.
Nursing homes, that's it.
Yeah.
Nursing home is nursing home.
Yes.
It's quite different than living with a family. I think we'll start thinking when the cost of nursing home, you know, they use up 7% of the budget given to the elderly. 7%, the others suffer from it. But the nursing homes, needed as they are in our culture, it's much better to have homes, family homes.
Are you actively doing any research right now in geriatrics besides writing? And
not at the moment, for a very simple reason. The government doesn't feel it's worth putting in money in that direction. So grants are virtually unknown. Family care, geriatric care is now in the hands of people who inspect nursing homes. They should inspect people in the nursing homes. Right. And there are enough numbers so that you can talk to a young gerant and an old senile gerant. What is the difference? One, the daughter-in-law comes regularly, and the other one, nobody comes. Makes the difference. So you keep that in mind, young friend.
I sure will. This has created a problem also in the dental office.
Yes.
Because we see now that our people are living longer, and you know what I'm going to say. We're going to talk about root caries. And is there any work being done in any of the universities that you know to help the general practitioner in his problem with the older person with all the root caries we're seeing?
Yeah, well, just to fill in children you have Pitt and Fisher decay. Mm-hmm. In young people, young adults, you have proximal decay. But in elderly individuals where the gum tissue recedes, when there's recession, exposure of the cementum to an organism called Odontomyces viscosus, which grows on the tongue. He forms a colony on, amongst the filiform papillae of the tongue and forms a coated tongue. And if the patient wakes up in the morning and there's this foul-smelling, ugly-looking accumulation of a white coat, we teach him to brush it off. Mm-hmm. Because if you leave it unattended, it can fall over to the exposed cementum and form a bacterial plaque and produce the entity called root caries, or cemental caries, which is a more accurate term.
True.
And before they go to bed, we teach them to brush the tongue before they go to bed, because during the nighttime, these organisms grow quite a bit. Is it common? Of course, it's very common. If you catch it early and teach your patient oral hygiene, tongue hygiene, you can stop it. Now, you spoke about the practitioner, what he can do. With the modern semi-adhesive or bonding materials, we can smooth off the area, teach the patient to keep it clean, but more important, fill in. It's a shallow cavitation. It's never very deep. Mm-hmm. It's too slow to go deeply. It rarely causes a toothache, but clinically it's quite visible. And root caries today is preventable, it's treatable, and it's easy, provided the patient seeks help from the practitioner.
Early enough. Mm-hmm.
The earlier the better.
Right.
There's a lot more to be learned about dental caries. For example, the fact that dental decay is an infection is, although well accepted by Fusuyama in Japan, for example, or in New Zealand, where I presented the first paper on it, dental caries is produced by bacteria. And if you can remove the bacteria, prevent them from colonizing and forming plaques, because you can have plaques, dirty appearing accumulations, without cariogenic bacteria. It's just dirty teeth, but there's no decay underneath. On the other hand, if you have plaques between the teeth and the rest look pretty clean, if it's infected with the strep mutans, you've got a lot of decay. And that still has not, in my opinion, been fully understood. It's in the textbooks, but in the practice, I think preventive dentistry has to go a little further and prevent infection of the teeth caused by the strep mutans, mostly.
In your teaching right now, Dr. Massler, I know you're not teaching with Tufts on a regular basis, but you are visiting professor at other universities.
Oh, yes.
And what are you teaching at the moment? Are you teaching graduate students?
Only graduates.
Only graduates, okay.
It's a self-selected population.
Mm-hmm.
You're dealing with people who really want to learn. You don't have to battle the lethargy of the very busy youngster who has a million things on his mind. The graduate students are very rewarding in that they learn outside of the seminar. We do this in seminar usually, rather than lectures. I don't like lecturing anymore. I'm never sure that the guy there is, and he's writing, it's not a letter to his girlfriend, rather than the subject under consideration. I would say that the main purpose of going to these different places is teacher education. It's labeled teacher education, but it's actually talking to the teachers, bringing up how much we don't know, how much we need to know, and how to stimulate, inspire, if you want, some of the young people listening to us to continue into research, clinical research, basic research. I'm amazed at how much has gone on in immunology with these youngsters in graduate school. My, they know more about immunology than I do. They've kept it, they're working with it. That's very important. And at the present time, oh yes, they ask me to come. I go frequently to other places like Temple in Philadelphia, Pittsburgh, UCLA, Alabama. It's very rewarding to talk to these future educators, that they are laying a basis for knowledge, but understanding comes a little bit later. If they deal with students, graduate students particularly, how many graduate students have really been the first assistant to some of the Nobel Prize winners? They always had one or two very intelligent graduate students who enabled them to win the prize. They didn't do it alone, couldn't. No one man is that smart. But you get some young people. Now, that is a fundamental objective of my going to Lima, Peru, Venezuela, even in South Africa, where sometimes the situation is very not satisfying. But all third world countries, I believe, at the present time, are very acutely conscious of having or wanting to learn from the Americans, from other countries. They no longer feel, they can't afford to be isolated anymore.
Well, the world's too small.
Much too small. Students of my young daughter in Israel is to help some of these emerging countries how to grow tomatoes in the desert, in the Negev. And they're doing it beautifully. Not only roses, but how to get a fish pond. You know, there they have fish in a pond, and then when the soil, which was barren before, is now well saturated with the effluent, with the fecal returns of the fish, they take the fish and put them in another pond, and now they grow wheat in that pond, corn. That is the way I think the world is going. It's going very rapidly. If the bombs don't catch us,
we hope not.
Research will make us enjoy life much more than ever before.
In the world of education, what do you foresee in the future, say between now and the year 2000, maybe, in any change in dental curriculum for the young student that's coming in? Some basic changes that may be taught, or maybe was taught in the last 10 years, that would be revised or maybe taken out of the curriculum, or new additions to the curriculum. You got any thoughts on that?
Yes, been thinking about that very seriously. I believe in the next 10 years, the student will be recognized as a person who can learn by himself. And what he learns by himself, he will remember much longer and understand better. Therefore, the textbooks, which are now on library shelves, will be studied and incorporated in the education of the student. But he has to learn to do that himself. He has to learn that anything worth knowing is worth striving for. That the passive student of the past who sat in lecture halls with 200 people around, and half of them not interested, and some of them with other problems which are diverting their attention. I don't care how good you have a lecturer. He's only a lecturer. The book is a better source of facts and information, and then will change the curriculum so that he's exposed to patients much earlier. For example, at Tufts, we have the first-year students already in the clinic. He acts to help a senior student clean the instruments, retract the cheek, but he becomes patient-oriented. And that patient who, when the senior leaves, becomes his patient. And if at the end of 4 years that patient is much better than when he entered Tufts, then we know it's a success. If he's worse, then it's a failure. And that's the only grading that goes on. It's terrible. So will it change? Oh, it will change tremendously as we recognize to identify talent and help to develop it instead of stifling it. That's education of 1990.
What do you feel is probably your most important accomplishment in your educational endeavors?
The most important and the most rewarding are the more than 80 graduate students who now occupy important positions in the educational field all over the world, where they're beginning to understand and to practice the difference between just teaching and educating. I think these graduate students are the ones that give me the greatest satisfaction, the greatest reward. And some of them are real geniuses, and you hope that they will continue to improve the teaching-learning interaction the way that we try to get them to understand it. And from what I hear from them, I think they understand. They understand very well. And they are touching other faculty people into a shift from just teaching to educating. Now that's a big accomplishment. And it's occurred, I think, as rapidly as society allows us to do that. How many of these former graduate students have given up a lucrative private practice to go into part of full-time teaching? Because it is there they find their own fulfillment. If they've learned that, wonderful.
This you kind of see a part of yourself then that you're leaving for the profession.
It's like, I think of them as I'm beginning to think, not of my own children, but my grandchildren. When I talk with my grandchildren and they tell me things, I begin to realize that my graduate students and also faculty who have changed from teaching to educating in different countries all over the world, that the feedback is worth all the time and effort. I thought I was doing this because of ego satisfaction. It's not true. I have plenty of ego. Enough of it has been satisfied. But to realize that a Tom Barber at UCLA who chose to step down from the deanship so that he can go back to contact with the students, that's wonderful. And the 6 graduate students who are now in India, a country that needs desperately more than money. It needs understanding of what a huge human problem it has. Or the schools, not only in Germany, I was in Dusseldorf just before I became ill, that these were people who were learning to understand. Why do we have continuing education? We must have continuing education because you're not a finished product when you get your MD or your DDS or DMD.
Correct.
That's the beginning of learning. But now it's self-learning. It's not passing exams.
Correct.
It's not that purpose. I think as I look back over these rather strenuous years, you know, being away from home for 3 or 4 days in order to work intensively, about 20 hours of each day, I thought was fulfilling me. No, not enough. It was promoting things like a dedicated religionist believes very sincerely in his faith, and he wants his faith to heal you. We believe that if medicine and dentistry would learn to take care of people and satisfy their needs and wants, that we will have much better patient-doctor relationship. We need that.
With that in mind, do you have any any thoughts what's going to happen in the office of the general practitioner with his relationship with his patient? Changes that may be taking place?
He will become the average practitioner in medicine especially, or in dentistry also, is overloaded. He hasn't got the time to deal with the patient. If he gives the patient, let's say, 20 minutes, he expects to accomplish a certain amount of work. He's a workaholic. Now, what's more important in geriatrics or in pediatric dentistry, or in pediatrics medicine, or geriatric medicine? What's more important? The relationship of the dentist to the patient, the physician to the patient. The biggest complaint I get from some of my medical patients is that my doctor doesn't have the time. Even if the patient is in the hospital in a bed, he runs through the ward. Oh, how are you feeling, Mrs.? And on he goes before the answer is there. That's not good medicine. Now, in dentistry, the same thing. If you're having patients only to get a new bridge, there should be equal time given to treatment of the patient. To let the patient tell you about the son who doesn't come to dinner anymore, but the wonderful grandson she has, and to ask the son and the grandson to come and visit you, to become part of the family. It's too expensive for us to go to the family. You have to become a family dentist, even though you're a specialist in root canal work. If you know the patient and the family, you'll do a better job for the patient. That's the future. How soon will it come? I don't know. You'll make it. I'm not sure about me.
Well, I was just going to ask you if you'd come back and see us in about 5 or 10 years, and we'll see if all this that we've discussed is coming to pass, or just what's going on in this world.
It'll come. It'll come.
And
5 or 10 years, I don't... Progress is either quick and it occurs soon, or it takes an awful long time. The change in medical and dental practice, giving more attention to the human, attached to the teeth or to the liver or to the blood pressure. It's too simple to say, you will have a heart attack because your blood pressure is up. It's not enough. Why is the blood pressure up? Not why only socially, if he's a workaholic. But if he's a workaholic, that's fine, provided it's non-stressful. But if it creates stress, it's going to be harmful. Now, that has to be part of the treatment of the physician's patients. It has to also ultimately become the concern of the practicing dentist. He is, after all, a doctor. He is, after all, a professional person.
True.
And the patient is still more important than his liver, his lungs even. If he doesn't stop smoking, why? Who is irritating him to the point where he's using this instead of cocaine? Question. That's the future. Very soon.
Now, one thing that I would like to know is your future. What goal do you still have in your lifetime that you would like to see to fulfillment? Do you have one particular thing?
Yes, I would like to have more attention to geriatrics in gerontology. Not the ending geriatrics means the treatment of a sick patient, or an old patient, or a child patient, or of tissues. Gerontology means that we need a lot more work and understanding in terms of the changing physiology. I just listened to one of my colleagues who is working in cell biology, And his special area is the aging of cells of the human body. Now, there's an awful lot to learn and to put into practice. And I hope that I will continue in water needs, maybe some of the vitamin needs. Vitamin C is still a very potent addition, but not vitamin E. We don't know enough about vitamin, but you can sell a heck of a lot of it with all sorts of vague promises. And these promises are vague. They may be right, but they may not be right either. So there's a lot to learn, a lot to do, and I'm lucky in that the patients are my guinea pigs. I don't need a colony of rats or monkeys. I think I'm more interested now in the people, the patients. There's a lot of different, and then the students.
You're more interested in what's attached to the dentition.
Oh, definitely.
When the dentition is attached to.
Oh, the teeth are all right. I can fix those. No big challenge. But to deal with the needs and wants of the patient attached to the teeth, just like a child or an elderly person. Not every elderly person who needs a denture wants it.
True.
Why? And how can you re-educate to want what is good for them instead of thrusting it aside? And in geriatrics, we have that problem. Look, you can cut down the death rate on heart attacks 50% if you can get the patient to understand who he is, what he is, and where he's going, if you can educate him. Otherwise, you have to do a triple bypass.
Dr. Massler, wonderful. And I want to thank you. You've been a tremendous individual to converse with, and it's our pleasure to have you here to do this for the college, to take time out of your busy schedule. Even though you've been retired 3 or 4 times, you still have a busy schedule, to come to here and sit with me for a couple hours. And
well, I thank you for asking me, because the International College archives are becoming terribly important, because 50 years from now, you have captured some of the great people with whom you now give me the honor to become associated.
It's our honor.
Thank you.
Thank you very much.
Right.